Thank you to Dr. Saheen and Dr. Lin for those great remarks and introduction to my talk. There will be some overlap, but today I'd really like to spend some time thinking about disparities in colon cancer in particular. So I'm Aparna Parikha. I'm a gastrointestinal oncologist at the Massachusetts General Hospital. And I'm also a member of the recently formed MGH Cancer Center and Health Equity Committee. And though I do a lot of clinical and translational research, clinical trials and things sort of in my day job, health equity and access has been something that I've been very passionate about and involved with peripherally for some time. And I think it's really great that we are having these conversations about very much proactively thinking about how to improve health outcomes for underserved populations in the United States and abroad as well. And so I thank the organizing members of this conference too for really highlighting this issue and bringing it to the forefront, because it is such a timely and important issue that I think no longer can really be passively addressed and needs to be actively addressed as we sort of think about systemic bias in medicine and in oncology. So, what's challenging with GI cancers, even though today I'll spend most of my time on colon cancer, is that GI cancers are indeed a whole host of different cancers and organs. And so though I'll spend most of my time down here in terms of the colon, I think it's really important to note and point out that disparities do exist across all different GI cancers. And before I dive into colon, colorectal cancer, I'll show you some early data or some preliminary data on disparities pan-GI cancers. So let's set the stage across all cancers before diving into GI cancers some more. So this was recent data from the ACS, and this was a report that they put out for African Americans. And as much of the conference has been highlighting, what we see is that Black patients have the highest death rates and shortest survivals of really any racial or ethnic group in the US for most cancers. Black men also have the highest incident cancer rate, period. And Black women have a 7% lower risk of cancer diagnosis versus white women, yet they still have a 13% higher risk of death. So again, just highlighting that though we'll dive deep into colon cancer today, this is a problem that has been highlighted by many of the speakers in terms of sort of pan-cancer problems that we have in terms of racial and ethnic disparities. So what's challenging again is, as I said, the GI system encapsulates many different organs and tumor types. And each of the risk factors and epidemiology of each of the cancers is actually different. But notably, for primarily all of the cancers, most have a higher incidence in terms of Black-white incidence as well as mortality. Here, there's only a couple really that I've highlighted, such as esophageal, squamous and adenos, whereas there's a difference here with adenocarcinomas being greater in the non-Hispanic white population and squamous actually being lower in the non-Hispanic white population. But for 7 GI cancers, both incidence and mortality is higher for Black Americans. So let's dive into colon cancer now. So colon cancer is a high burden disease. It's the 3rd most common malignancy in the United States and is the 2nd leading cause of cancer death in men and women in the United States. Around 150,000 patients will be diagnosed and 55,000 patients will die annually. We are seeing some droppage of rates, but particularly for younger patients, we're actually seeing a rising incidence. Most of these patients being in their 40s, where we're seeing this couple percentage increase every year of what we call young onset or early onset colorectal cancer. There's lots of data that supports screening, and given this predominance now and growing incidence of young onset or early onset colon cancer, some screening organizations such as the American Cancer Society actually recommend screening now at the age of 45, independent of family risk factors. Family risk factors family history are an entirely different ballgame, but for an all-comer population, screening at 45. Yet, what has been noted and what we'll talk about is that there is some considerable racial and ethnic disparities in both screening and outcomes for patients. So what you can see here again is highlighting that, for overall there has been a slow decline, but still 5-year survival is 64% for all comers, and some populations aren't having this advantage of this decline. And, I think, it's important to not think of kind of race as all encompassing either. I think different racial and ethnic minorities have different challenges. What we see for African Americans or Black patients, for example, we see younger age of onset, we see the highest incidence of mortality, late presentation rates, low screening rates. Hispanic populations, we see kind of, again, later disease presentation rates, but we see, far lower screening rates. Asian Americans as well, we see lower screening rates. And then Native Americans, we see low screening rates, and then the second highest incidence of mortality. So I think as we sort of think about ways to address each of these populations and issues, it can't be uniform and needs to be directed towards the needs of that particular demographic. So in general, like I had said in the overall high-level overview of colorectal cancer, it is more common actually in men than it is in women. And when you look at combining all the different races here listed, the gender bias is not very stark, but it varies widely when you actually factor in race and ethnicity. And the greatest divide, as you can see here, is with African American males versus females, where you see an incidence of 61.2 versus 46 per 100,000 new cases for Black men and Black women. So even a pretty significant gender gap within this racial and ethnic minority group. So that was incidence. And when you look at mortality, again, males die more from it. They get it more, they die more from it. And similarly, we see a divide between genders, and that divide is greater when race and ethnicity were factored in. Again, African American males have the highest number of deaths per 100,000. Males identified as non-Hispanic, but not white or Black, had the second highest number of deaths, followed by Native American or American Indian and Alaska Native populations. Black females had a higher number of deaths, as you can see here, followed by American Indian / Alaskan Natives, as well as non-Hispanic and white populations. And, I think this talk, isn't really about different screening modalities and how screening is sort of universally applied, but I think what's important is that screening does matter, and screening reduces incidence and reduces mortality. And the reason is that if you look at survival rates at 5 years, when the disease is local and caught early, the survival rates are markedly different. So 90% at 5 years if it's local disease versus distant disease at 14 disease. And we know that universal screening is cost effective. We know that screening options vary. And so, and hence the recommendations for universal screening, although that age again is varied somewhat by organization and emerging data in terms of when is the best time to screen. But we have to sort of think about screening as an important part of the paradigm as we start thinking about some of the disparities within colorectal cancer treatment. So I just wanted to put this infographic here, again, just to highlight that for ACS, screening age is 45 now. And also I should note that for Black males, independent of this age and ACS, it was earlier screening recommended as well. These are some guidelines I'll just leave here for reference from other screening organizations too, based on age, but again, really just taking home the point that screening is important. So here is the overall cancer screening or colorectal cancer screening uptake from the CDC. It's some older data, but some data that I think at least does show that screening uptake amongst adults has risen over the years. And we'll look at some of the gaps between different racial and ethnic minorities going forward. So this data highlights some disparities in colorectal cancer screening in Medicare enrollees. So as we've shown here, as I showed in the previous slide, you can see that overall screening rates over time have increased. But on the bottom here, you can see this dashed line, Hispanics have the lowest percentage screen compared to other ethnic groups. And we see the differences here in Black patients as well as white patients over time. And actually, most of these racial disparities were actually explained by socioeconomic inequalities and differences in healthcare access. And we need to pay particular attention to Black and Hispanic populations. And I think it's really important as we think about how to improve outcomes for these patients when we're thinking about the spectrum from both screening to treatment, is not just, it's not enough just to really highlight the disparities and not enough to just attribute it to race, but what are the systemic issues that are driving these differences? And here what they showed was that Black and Hispanic Medicare enrollees actually earned less, they had lower education levels, and they were less likely to have supplemental health insurance. And the racial differences were actually attenuated when you adjusted for supplemental health insurance, and entirely disappeared after further adjustment for education and income. And so the economic drivers, the education drivers are important to think about in the context of addressing health disparities in colorectal cancer. And so I think that this study nicely shows that it's a combination of both socioeconomic disadvantage as well as limited access to healthcare that reduces the potential that expansion of coverage only will close the racial gaps in the use of colorectal cancer screening. And yes, there may be, biologic differences too. I think as some colleagues have highlighted with, breast cancer, for example, where triple negative breast cancer in African-American patients seems to be different and, get more aggressive, and they tend to get that variant more. I think there are also important socioeconomic constructs for us to think about as we think about working towards eliminating disparities. When you look at, again, in screening, we are showing here, this is looking at different health centers as well as low income nationally, that we see that differences in screening accounted for 42% of the disparities in colorectal cancer incidence and 19% of the disparity between mortality between Blacks and whites. And this data suggested that screening and survival actually explained a little more than 50% of the disparity in CRC mortality between Blacks and whites. So again, screening, really important, but per the previous slide, what are the barriers to screening for these patients? I think from the screening end, I think there's patient level factors, health literacy, knowledge, beliefs, education, income, as we talked about, access to care, some fatalism around cancer that certain populations have. There's systemic level factors, access, capacity, care coordination, reminder systems, some of which are electronic and may not be accessible for patients. And then provider level, so what are the guidelines for different minorities? For example, Black patients do have different screening guidelines than white patients given their higher incidence. And discrimination at the health system level, recommendations to screen. So it's not just one isolated thing, and all of these factors contribute to the cycle of perpetuating these barriers for patients. This was a systematic review looking at barriers to screening amongst Black patients that was done with a colleague of mine, Dr. Fulla May at UCLA. And they looked at nearly 500 different articles and different abstracts and papers and tried to understand some of these barriers to colonoscopy screening. And what they found here was, interestingly, in the African-American populations, fear was one of the biggest barriers to screening in their systematic review. And then what you can see here, so there's lack of knowledge, but then at the provider level, lack of physician recommendation. And then here at the system level, some of the things that we talked about. But I thought that this graph was quite striking in terms of just fear in this patient population, and what can we do to help alleviate that fear. And so again, I think this data highlights that it's a comprehensive approach to really think about how we can look at screening colonoscopies and the uptake of these procedures for African Americans, and not just one of these factors in a silo. So there's lots of different, efforts from various organizations. This is just one example, the Colorectal Cancer Control Program Learning Collaborative, which is looking at interventions to increase screening, as well as to provide kind of more direct screening services to uninsured or underinsured patients that are below the 250% of the federal poverty line. And they have some pilot programs in Alaska and DC. And again, really looking at these programs comprehensively. So it's not just one factor. It's sort of these feedback loops that are allowing for continuous improvement for these patients. There's a lot of messaging. This is some work that's being done by the National Colorectal Cancer Roundtable. And what you can see is, for example, compared to Hispanic populations, as we talked about, African Americans actually may have a higher likelihood to get screened compared to some other racial and ethnic minorities. But there's fears, their cost fears, their prep concern fear, and so there's a lot of messaging that is being thought of that can help try to ameliorate some of these fears and concerns that contribute to the barriers. And so they did some messaging, and they looked at baseline screening likelihood before the messaging. And here are some of their examples of the messaging that they have provided for patients. And for example, colonoscopy isn't the only option. There are simple, affordable options, including tests that can be done at home. Talk to your doctor about it, ask which tests are covered. And, the hope is that they'll say, okay, I'll prefer to explore these other options that are less invasive and more affordable. And if you look at the messaging, it wasn't a drastic increase, but from baseline 34% to upwards of 40% for various baseline screening to, with messaging, and how the perceptions increase with messaging. So a few examples of disparities in treatment. So this was a study that was done looking at NCDB data, and NCD database is a large database and looks at outcomes and treatment for pan cancers. And this was a study that was done, and they looked at nearly 90,000 stage 3 colorectal cancer patients, and from the early 90s to 2002. And in stage 3 colon cancer, the standard of care is to receive adjuvant chemotherapy. And they did find that there was some increase in use of adjuvant chemotherapy over time, so 39 to 64%, but it was lower in Black patients, female patients, and elderly. And we know that adjuvant therapy does increase survival. And they looked at it, and they showed that adjuvant therapy benefits the elderly as much as it does the younger patients. But interestingly, the benefit of adjuvant chemotherapy in Blacks was not as great. So even though Black patients weren't getting quite as much of adjuvant therapy, notably the benefit of adjuvant in this large data set was not quite as high. And that speaks to perhaps there is this biological difference too that really needs to be understood. And maybe chemo isn't just chemo, and we really need to think about, are there certain differences in terms of at the patient level that are driving these biologically too. Women and elderly patients, again, they have the same benefit, but less often treated than sort of white men. The other, I think, good example of treatment disparities came also from NCDB data, and they looked at the recommendation of surgery, pan stages, so stage 1 to 3, so not metastatic, but in resectable patients. And they had 170-some thousand patients that were recommended surgery, and they had 1,100 or so that refused, and they found that increasing rates of refusal were associated with elderly patients, African American race, and then the CDCC, which is a comorbidity score. But again, when you looked at decreasing rates of surgery refusal, higher income private insurance, and when you stratified by stage, the refusal rates amongst African Americans remained disparately high. And not surprisingly, if you refuse surgery, you did worse. So it's critical to really understand what are the systemic causes leading to this. Again, income insurance seem to be linked as well. And we're seeing that, yes, older patients may not want surgery, but race again is coming up as an important issue. So in terms of disparities in access, I think we know here from colon cancer, use of prevention and early detection is really important. Access influences the receipt of cancer treatment and also influences survivorship care and follow-up care. And without health insurance, we know that people are more likely to be diagnosed with advanced cancers and have a higher risk of cancer death. When you look at just insurance alone, in 2017, 11% of Blacks versus 73% of whites had private insurance. And so I think, again, I put some quotes here, but also some pictures I liked in terms of, healthcare, I think, including access to cancer care is a human right. And as Martin Luther King said, of all the forms of inequality and injustice, in healthcare is the most shocking and inhuman of them all. So here's my blue ribbon for colorectal cancer. And I hope that these conversations that we're having today behooves us as a community to really move the needle. We have to do better. We have to put money and resources into understanding the social determinants of health. We have to address barriers to screening, to improve screening. We have to ensure that there's education and dissemination of knowledge for all patients, improve access to healthcare, and really to improve the population of health, population health. We really must, hope to aim to achieve health equity. So, here are from 2022 people that succumbed to GI cancers. The phenomenal John Lewis here, as we all have heard, getting good necessary trouble. John Lewis passed away from pancreatic cancer. And then here we have Chadwick Boseman. In times of crisis, the wise build bridges while the foolish build barriers. So let's build bridges towards battling inequity in cancer care. And I'll close with a MLK quote: "Our lives begin to end the day that we become silent about the things that matter." So thank you to all their patients and their families, to all the advocates fighting for health equity, the THI team for organizing this, and Dr. Folomé, who again is a gastroenterologist at UCLA, who studies colorectal cancer and disparities and was a tremendous resource as I was putting together this deck as well. So thank you.